Our intention is to do it not really informal, but as informal as it should be, because we're gonna like to discuss a lot of issues. So I'll do a brief presentation. This is our faculty. I am André Pedrinelli from Brazil. We have Dr. Pedro Pessoa from Portugal. We have Dr. Lugos Hazira from Czech Republic. Also Dr. Mauricio Fadel from Brazil. So we have a very widespread range of panelists. So this is very important because we have worldwide experience. So this is our disclosure. So all of us, the panelists, were invited for MIT to bring their knowledge here. And we have here a brief introduction of what we're going to discuss. I'll give an overview of the product. Then we have Dr. Pessoa. We're going to talk about ankle. Dr. Hazira will talk about how to use the ultrasound. And Dr. Fadel will talk us about epicondylitis and his experience. Then afterwards, we're going to some practical demonstration here with the use of the ultrasound, so we can lively see how does it operate. Then we'll also get questions and answers and some remarks. So, okay. So the goals, what would be our goals today? We're going to go from theory to practical issues. We're going to understand the principles of use of this kind of injection. We're going to see acute cases and chronic cases. And we're going to understand how to do it safely, which is very important for our patients. Then we'll have questionnaires. And there's no reason for crying, okay? It will be knowledgeable for everybody. And we're not trying to bring such new things, because as doctors, injections is part of day-by-day workshop. So STABHA is well distributed around the world. You can see here we may have some different denominations, but the same product. So we have a worldwide experience. And first of all, this kind of product as a hyaluronic acid is not a doping. So as we are in a sports medicine conference, it's not able to say that this is no doping at all, even the procedure. Besides, we have the no needle policy by WADA. That's what every time we use something injected, we should communicate to the WADA. This is no concern about doping control. So I would like to do an overview just for us to standardize our knowledge about the things. So what is really important? We have some structures about the tendon. So the tendon's majority consisted of water plus a few cells embedded in what we call the matrix. Matrix is the key point nowadays for understanding the structure of collagen tissue. So tendons, cartilage, and ligaments and synovial also behaves almost like the same. And this is very important because we have the range of elongation of the tissues. They're almost the same. Every collagen tissue works much better. We just have 4% of elongation. So in between 4% and 8%, we have a physiological effect. After 8%, we start having ruptures. That's where the quality of the matrix is so important, because if you have a good matrix, we can sustain at least 8% of elongation. This is the main point. So the glycosaminoglycan is a polymeric issue, and the thing is that the most important, it's charged negatively. All the inflammatory process is charged positively. So we have the piezoelectric effect that we should understand quite commonly, because this can diminishes the inflammatory process, which might be important because the way we have the production of the STABHA. This is just a brief history of how the hyaluronic acid was found. So it was discovered in 1934, and the first periarticular use, what we're going to talk about, was in 2000. So very new approach of using hyaluronic acid. So the main thing that's the hyaluronic acid is molecular, and the weight of the molecule is very important because we're going to have two different aspects of use, interarticular and extraarticular. We're addressing here the extraarticular use of the hyaluronic acid. So the weight is very important. So we're going to go through heavy chains of hyaluronic acid. Normally it's used like a lubricant, but as it acts to change the way of the matrix behavior, this can support loads. This is very important for tendons and also for extra-articular structures, because you know when we walk, we discharge 2 times our body weight, and if we run, this can be in between 4 and 8 times our body weight of discharge. So having healthy tendons, healthy articular structures is very important to sustain load even for just walking. Okay, so this is the areas of the body that we have hyaluronic acid. So you can see, maybe we can tell that's everywhere in our body because it's a component of the matrix. So the behavior of the product is almost like this. We can have the blockage of the prostaglandins when we have a tissue lesion. So this is enhance the possibility of diminishing the inflammatory process. So, and now the effect is regulating the inflammatory, as I told you before, is improving the sliding. What I mean sliding is because each tendon has a different architecture. So as for instance, the Achilles tendon is an helicoidal arrangement, and the patellar ligament is a straight line forward. So this means what? Difference of behavior of each tendon. So each tendon has to be addressed in a physiological way. So, and also we have an anti-allergic action. This is very important to address. Okay. So as I told you before, we have 2 main uses of hyaluronic acid, interarticular and extraarticular, and we will address the extraarticular one. So we do have a lot of different products, and the main difference are the molecular weight, the different sources of the raw material. Mostly we have the rooster crest and the use of molecular filtration. We have different concentrations and we have different regimens, 1 to 5 injection. This means a very financial and healthy important issue, because if you inject 5 times, 1 time each week, you may have the possibility of the enhance of the appearance of infection. So this is one thing. And also you're going to have 5 times the doctor, or 5 ampoules, or 5 other things. If you do it once, it's much more financial, feasible, but you have the type of concentration. So this is the thing you're going to have to understand. So how it's produced? We have 2 different types. We have the roaster crest and we have the fermentation, which uses bacteria induced. So what's the difference? We use the Streptococcus equi and we use a filtration because the whole thing is about dead cells. So on the process of production, you produce dead cells. So, and with the filtration, you separate this from the main component. So that's why we have the purity of the product. So, and we can enhance his process of action. So this is just an overview. Please don't pay attention to this. And what I'd like to do is address that since 2002, we have been published articles in the literature about the way we use the hyaluronic acid. So we have 2000, 2002. We have on 2002, 2007. Petrella is a person who produces a lot of literature about this. And we have also different outcomes with reduction of pain. Remember one slide that I showed before, that one of the actions of the drug was to restrain the inflammatory process and also restraining the presence of issues that lead to pain. So, and from the point of view of the lateral epicondylitis, we have this nice work from 2010, which shows improvement in assessment global of the elbow. So we have release of pain, we have diminution of inflammatory process, and we have better development or range of motion in the articulation. So, and also in the Lancet in 2010, we had the first randomized study with trials showing it has a good effect. And also in, let me see here, 2013, the same thing, the reduction overall pain. This is the main source of good results of the product. This is a very important issue to address. And also, one of the last papers, again addressing pain, walking pain, rest pain, and also return to work. All the issues reduced by the use of the hyaluronic as extra-articular. And one of the last papers we had produced, 2016, showed no difference in postural stability and double leg stance between, but the results were significantly higher for injured leg when compared to the leg that we use the STABHA. So this is just for giving a brief introduction. Thank you very much, and I would like to invite our next speaker, Dr. Pedro Pessoa. Please, the floor is yours.
Good morning to all. I treat professional football players and elite athletes for more than 20 years. So, you know what's the first question that they ask me? When I can come back to play again? And the second one is, I'm going to be 100%. And this question is going to be repeated for the coach, for the president of the club, for the manager, and for even sometimes from the coach for national team that wants to know if he can play in the next championship. And what's the difference between athlete football players and the other ones? That's injury costs money, and here costs more money. And as you see, for a minute, for a second, it's a huge. And as you know, and as you see here, there are these two ankle sprains in the same season. It's very, very important. The anatomy of the ankle, it's easy. We have three main ligaments: the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. The anterior talofibular ligament is only injured in 2/3 of the cases. 20% is associated with calcaneofibular ligament, and calcaneofibular ligament is a rare lesion isolated. We have the mechanism of lesion is like this. This is Jefferson in my club, and you see he put the foot in inversion and after adhesion. So when the foot is in plantar flexion, you do a supination. So the anterior fibular ligament is on tension, and it's the first one to have the injury, to have the rupture. So numbers, it's a lot of injuries. 1 in 10,000 per day, and 50% of them are sport related. And the sprain, usually you say to a patient, it's a sprain, it's not a problem. But 40% of all sports lesions are sprains, ankle sprains, and 29% of the football injuries also ankle sprains. 12% of the time away from play responsible is ankle sprains, and 1/3 of the cost of sports injuries are due to ankle sprains. So it's a lot of money, it's a lot of costs. Also, we know that more than 50% of the sprains, of ankle sprains, occurs from direct contact. The athletes with a previous sprain have higher risk, is double. And 12 weeks after, only 60 to 90% of the athletes are in good shape. So we know also that they have more lesions in competition than during the training. And for orientation, you can say to the coach or to the player, if you have an initial sprain, you can say, okay, you are going to be 3 games out, and if it's a recurrence, you say at least 4 games out. So most of them resolve with conservative treatment, less than 20% require surgical treatment, and 20 to 40% of untreated lesions can lead to chronic symptoms. This is a paper for 2006, International Ankle Consortium. Is a statement consensus that say, okay, high recurrence rate after the first ankle injury, but we can have a potential chronic anterior instability, and the chronic anterior instability is a lot of times associated with premature osteoarthritis. Physiopathology, what do you know? We know that we have some intrinsic factors like strain, range of motion, balance, and proprioception. And if you have a patient that is coming from a lesion, or if you don't have isokinetic test well, and if you have some limitation in arcs of movement, yes, you can have more trait to have another ankle sprain. Of course, the proprioception here is very, very, very important. If you have already ankle sprain, you know that there are higher risk. Hyperlax type is they have more ankle sprains and also more knee sprains. And malalignment, or like varus, cavus, valgus, yes, it could be another factor. Sports related, yes, we know that basket and volleyball, they have more sprains, ankle sprains. If you have more athletes, more contact lesions, more ankle sprains. Training, we have already saw that competition is worse. Floor surface, you know, that's the only thing that we know sure is that synthetic is bad for the ankle. And the field position, if you have more contact, if it's a defender or striker, we can have more ankle sprains. Physical examination. The gold standard should be at 4 or 5 days after the lesion to evaluate, and we can have a good classification. We can see this slow and full fit, and with the bruise, localized bruise sometimes. And the classification, we can have 3 grades. The first grade, we have a middle stretching without macroscopic rupture, so no instability. It's the usual one, is the majority of ones. In grade 2, we can have a partial rupture with moderate pain and swelling, and we can have a slight moderate instability, and complete rupture with marked pain and swelling and hematoma. You see, in the first place is grade 2, and the second one is a guy that is going to be operated in the grade 3. We know that also that there are 3 phases. Initially, we have inflammatory phase in 10 days, after proliferation phase until 3 months, and finally maturation phase. In the beginning, we should avoid injury aggravation and use price, and I put a cast or a removable boot. After it's important to avoid inversion, so it's better to put a functional like this one. And in the final, sometimes we feel that the patient is okay, the athlete gives us feedback. I'm okay, doctor. After 6 weeks, you can do. Now it's important to maintain the functional in the trainings, in the games, in the competition. Otherwise, we can see that after 12 months, you can only have 80% of tensile strength. Now we start with our goal, the treatment. Usually we do initial treatment, 10 days of immobilization, price, lace-up brace or functional immobilization, anti-inflammatory drugs, and rehabilitation. Physiotherapy, proprioceptive training is very important. So, but we are in the football players, you know, and we need everything. And when we have a lesion, a sprain like this, they look everything. This lady do injections of placenta, horse placenta to treat muscular lesions, and they go there. They want magic. They want miracles. You know that there are no miracles, but they want it. So when the Diego bring me this product, hyaluronic acid, I have some experience with intraarticular use. We have already shown that we can have better healing quality, we can have decrease of formation scar tissue, we can also reduce adhesions, and we can have promotion of correct alignment of the collagen. So it can work in the two phases, in phase 1 and 2. It can also decrease the pain, it can accelerate the decrease of the pain, and seems to me good. But does it work? Or it might work? This is my question. There are clinical evidence, of course, and we have already saw these papers for Jacobs and Petrella, and we see that we can reduce the time, we can reduce the pain, we don't have serious effects. So I try in 10, 12 of my patients, and 10 males and 2 females, 1 handball, 1 runner, 2 basketballs, and of course 8 football players. And the age is between 19 and 42 years. The pain, the initial score was 6. The treatment was rice, and the athletes receive an injection of sport visc in the first 48 hours. And the assessment had been done at 4 days. The average reduction of pain in both in rest and walking for 3.7. All the athletes were satisfied with the treatment, and also we don't have any adverse effects. So when I have a sprain, ankle sprain in a patient of mine, like a flat tire in Formula 1, and then these guys are Formula 1. We can put in the box sports visc and put him back to business in the same level. Thank you very much.
So good morning, ladies and gentlemen. I try to demonstrate to you another possibilities how to use sport with STABHA, because in the real beginning the on-label diagnosis was the ankle distortion grade 1 and 2, and we tried to find spreading the diagnosis out label, but okay, in the medical part without any problems and side effects. So we try to find the possible negative side effects to be like artists in our treatment. So we used the STABHA in different regions, and we can demonstrate to you our results. Certainly we try to put STABHA exactly to the place where we will. That means we use the ultrasound navigation with a special possibility of new ultrasound machines. That's needle visualization. It's called different in different machines and companies. For example, in Canon it's Super Needle, in Samsung it's Needle Mate, Alpine Needle Vision, and. But what's important, the needle is very precisely to visualize, to put it in direct problematic place. So you can see here the needle application in the rotator cuff tear. That's on your left hand side. On the right hand side, you can see the healing after injection of STABHA directly to the defect, into the lesion. We can use STABHA also for destroying calcifications of this so-called needling. With the needle, we can apply the STABHA directly into the calcification which we destroyed by the recurrent needle putting directly into the calcified point. Another problem is to use STABHA by acute muscle injuries. We can put STABHA directly into the muscle lesion just after the injury. If possible, we try to evacuate the blood and then we apply the STABHA. But if we are not satisfied with the evacuation of the blood, we can put STABHA directly into the hematoma without any risk of negative side effects. So again, on your right hand side, you can see the patient after the STABHA treatment, after quite big injury of the hamstring muscles. Certainly we can use STABHA into any fluid for example, encapsulated hematoma or seromas or bursites. It can be a small one or big one, because with STABHA we can find again optimal place where to put the injection directly into the fluid. If we have, for example, post-resectional big fluid mass, so in this moment we can use STABHA together with steroids, for example, the pomedrol or solmetrotrispan, and it's without a complication. So I discussed it in the really beginning also with Professor Petrela, and he had no problem with application STABHA together with steroids. So certainly we can have also acute situations. For example, this is a décollement injury. That means tearing the skin from the tissue. So we can put STABHA directly into the fluid. Slowly, directly into the fluid between the scar layer and the fascia layer. So the healing is very quick. In a few days, there are no problems after these injuries. This is so-called deep infrapatellar bursa. It's butterfly shape in the short axis. This is the patellar tendon. This is the fluid in the bursa. It's longitudinal view, and fluid below this patellar tendon. We can put again the STABHA directly into the bursa, and the healing is going very fast due to the thixotropic effect that STABHA can absorb the fluid, and the bursa is healing very quickly. We can use it also in acute injuries. On your left hand side, you can see acute post-traumatic prepatellar bursitis. We can again use the STABHA and put it directly into the bursa. On your right hand side, you can see so-called pre-Achillei bursae. In this moment, we put the needle in the anterior part of the bursa, and the STABHA goes down for the all region of the pre-Achilles bursitis. You can see that the Achilles is divided from the calcaneus, so we can put it very precisely. Very strange application, but with very good results. Is irritation of symphysis. It's very often in football after blockage of sacroiliac joint or after direct injuries. In that moment, we can put STABHA directly between the pubic bones, again with very good effects. Enthesopathies, that's another problem. We will have a special lecture about it. But enthesopathies are very often together with overuse and wrong stereotypes of sport activities. In this moment, we have seen quite a lot of recidivism due to non-compliant patients without possibility to protect this region. Patellar tendinitis, it's in two different situations. In sports medicine, we can see the jumper's knee, it's tendinitis of the apex tendon. But when we have classic tendinitis, we use STABHA and put it in the border tendon soft tissue in surroundings. If we have pathological neovascularization of the apex, we can put STABHA directly to the bridging veins. Very similar situation is when we have tendinitis, for example, Achilles tendinitis with new pathological neovascularization, which is conducting the inflammation. In this moment, we put STABHA below the Achilles. That's the position of the needle, and with the movement of the needle, we cut the bridging veins, and we destroy the communication between soft tissues in surrounding. And STABHA makes a layer which can help us to heal the tendon and to protect for recovery of the bridging veins as neovascularization. Certainly, if we have partial rupture of Achilles tendon, do not hesitate to put STABHA directly into the lesion. So in the first moment, when I saw the first patient, for me it was a shock between because the fluid of STABHA makes a big depot in the Achilles, but 2 days later I cannot see anything in the Achilles. And I have really no complication, and all my patients were here. This is a panoramic view of some complete rupture of Achilles. Certainly, normally, it's indication for surgical treatment, but some patients are not willing to go to surgery. So in this moment, I try to use STABHA together with plaster of Paris bandage for 6 weeks. And the Achilles was healed completely without any residual problems. I will mention in the end the ankle, because in the beginning it was indicated only for ankle distortion grade 1 and 2, as we have heard in the first lecture. But we try to use it only also in the grade 3. We use ultrasound forced position in local anesthesia for distinguishing the grade 3. So we can exactly find on ultrasound the instability, and we put STABHA according to Petrella fan shaping to the ankle, and we have very good results with this application also in this grade 3. But what's necessary to know that sometimes is by ankle distortion also irritated the syndesmosis tibiofibular. So it's also lesion of tibiofibular and anterior ligament. So in this moment we can see directly on ultrasound, and we put STABHA also directly to syndesmosis. So if we have grade 3 distortion with irritation syndesmosis, we use directly one injection into the ankle and another one to the syndesmosis, and then we put plaster of Paris bandage for 5 weeks. So our results. We used STABHA in more than 800 patients. We evaluated for this situation more than 400. You can see that we haven't any bigger problem or complications, only pain after application. We can see approximately in 14% of patients. the positive effect is more than 90% from our patients. The recurrence of trouble by load and sporting activities we have in 15%. It was mostly tendinopathies in non-compliant patients. With combination in steroids, we used this application in 23%. It was first cystic affections, but we try the STABHA also to use in oncological patients. That's a question for future for discussion, because certainly STABHA can increase the proliferation effect, but if we have oncological patient with huge post-operative seromas, so in this moment we were very satisfied also in this field of treatment. So in conclusion, we can say that using STABHA is a very safe method with minimal risk of complications, with no damage of injured tissues, and we can recommend it to another applications. So if possible, I can only demonstrate you very briefly the possibilities where to apply STABHA on ultrasound.